Welcome back to the Neurophilia Podcast. I am your host, Nooper Goyle. If this is your first time listening to Neurophilia, or you are a longtime listener, we want to thank you for taking some time out of your day to join us. Neurophilia is a medical podcast show focused on interdisciplinary conversations to connect neurology with other fields of medicine. With each episode, we hope you develop an appreciation for, and perhaps even a love of, neurology. In today's episode, we will be discussing the relationship between neurology and palliative medicine. In the 1970s, palliative medicine emerged as a field away from hospice care to mainly provide specialized care for people with serious illnesses such as cancer. Over time, palliative care has grown to include patients with chronic, lifelong conditions. Many neurological diseases have no cure, leading to significant and chronic physical disability as well as emotional distress for patients and their loved ones. For example, studies of patients with motor neuron disease found significantly higher scores of demoralization, hopelessness, and suicide ideation when compared to patients with cancer. Because of this, the field of neuropalliative medicine has become more and more recognized in recent years. Neurology often requires palliative medicine involvement with advanced care planning, transition to hospice care, discussing prognosis and treatment goals, and addressing psychosocial needs and caregiver burden. Burisma et al. Writes, as neurologists care for patients with chronic, progressive, life-limiting, and disabling conditions, it is important that they understand and learn to apply the principles of palliative medicine. Although the need for neuropalliative care is present, the amount of formal training available is limited. Less than 52% of neurology residencies provide formal didactics pertaining to palliative care. And one survey of neuro-oncologists found that only 51 providers felt comfortable dealing with end-of-life discussions and symptom management. All studies and statistics mentioned will be available in today's episode description. To discuss the relationship between neurology and palliative medicine, I have with me vascular neurologist and Neurophilia co-host, Dr. Blake Valetko, and two very special guests in the field of palliative medicine, Dr. Kathleen Neuendorf and Dr. Renato Samala. Dr. Kathleen Neuendorf, MD, has been a palliative medicine physician working primarily as a consultant in the hospital since 2010. She was drawn to the field because it brought an honesty and clarity that people seemed to need but weren't always getting. Dr. Neuendorf is known both locally and nationally for her work in relationship-centered communication and leadership. Outside of work, she is a proud mom of 3, enjoys spending time with her husband and taking walks in the Metroparks. Dr. Renato Samala, MD, is a staff physician in the Department of Palliative and Supportive Care at the Taussig Cancer Center and an associate professor of medicine at the Cleveland Clinic Lerner College of Medicine. After graduating from the University of Philippines College of Medicine, he completed a residency in internal medicine at UPMC McKeesport and fellowships in geriatrics and hospice and palliative medicine at Cleveland Clinic. Dr. Samala is a fellow of the American College of Physicians and the American Academy of Hospice and Palliative Medicine. He has written numerous articles published in peer-reviewed journals and textbooks and has presented at local, national, and international conferences. Dr. Neuendorf and Dr. Samala, thank you for being here on the Neurophilia Podcast.
Yeah, we're thrilled. Thanks for having us.
It's an absolute pleasure. Thank you.
Well, I know that we have so much planned for this episode, so I don't want to waste another minute. Let's jump right in. The first question that I wanted to ask you both as specialists in palliative medicine, what are some common reasons that you have seen in your practice that are reasons for collaboration between neurology and palliative medicine?
Yeah, Renato, do you want to start with the outpatient perspective?
Sure.
Or why don't you do outpatient and then I'll do inpatient?
Yeah. So for me, things started in 2019. So the chairman or the head of movement disorders at Cleveland Clinic, he connected with my department chair, Dr. Laura Shoemaker, in order to forge a collaboration between our groups, our departments. And thus, was born CARE-PD, or Comprehensive Assessment and Treatment Program for Parkinson's disease. And it's a special clinic. We do it twice a month at the Neurology building. And I'm partners with a movement disorder specialist and a social worker, and all three of us see patients all at once. And these are typically patients with advanced Parkinson's disease. So to answer your question, my role really is to fill in the gaps in the care of these patients with Parkinson's disease and Parkinson's related disorders. Because it's an idiom, it's cliche, but it really does take a village to take care of these patients and their families. So I in my line of work, I take care of symptoms, mostly non-motor symptoms such as pain, constipation, etc. And then also do some basic advanced care planning for these patients and their families.
Yeah, and I'd say, Renato, everything that you said about Parkinson's disease, Newport, to your point, can really be related to any of the chronic neurologic diseases. For us right now, we're really focusing on Parkinson's, but what Renato does can be done with many patients who have some sort of, when you think about MS, Huntington's disease, and the list goes on. My collaboration with neurology happens in the inpatient setting. I do a lot of work in the ICUs. So that's where Blake and I get to interact often enough. And I usually see patients where there's an uncertain neurologic outcome. And I'm trying to have families, the patient's families, make sense of what we do and don't know about what the future might hold. So I would say most of the time, patients will have stroke, maybe subdural hematomas. Status epilepticus is something that we see, and encephalitis has been something I've seen more in the last year than I feel like I've seen in my 10+ year career so far. 2 weeks ago, I had a patient who had CJD. So there's also natural collaboration, I would say, with dementia and other progressive neurologic diseases, and only some of those do we see in the hospital.
Newport, can I do a timeout?
Yeah.
Katie, I don't know if it's on everybody's, whenever you're chatting, it's a little bit muffled for me. I don't know if it sounds the same, or Newport, I don't know if you want to check the recording. Sometimes it comes across a lot clearer on Zoom. Is it just me?
It's happening
Maybe it's
a
just
little
me.
bit for me.
I could just unplug these and see if that's better. I'm in the room's okay.
We can try it. Yeah, try it.
Does this feel better? Can you hear me okay?
Yeah, that sounds much better.
But it's not seamless, Katie. Yeah, but now it's much better.
Yeah.
Okay. All right, great. So do you want me to say that?
It's up to you all. Sorry, I figured, I was like, well, if it sounds like this to me and it's like it's recording this the whole way, I'd rather just see if you unplugged, if it sounds better. But you sound much clearer to me now. So Newport, it's up to you.
Yeah, I mean, I feel like we're early enough in the recording that if you wouldn't mind, Dr. Neuendorf, please.
Not at all.
Such a wonderful response.
Sorry.
That's okay. I wrote a lot of these down. I have so many thoughts that I wanted to keep them.
Perfect.
So,
Perfect.
Yeah.
Thank you.
I can repeat it. So Renato, those are some of the pieces from the outpatient setting, and obviously many of the neurologic diseases, when you think of not just Parkinson's, MS, Huntington's, what Renato does can apply there. I'm mainly seeing patients in the inpatient setting, and I would say the collaboration happens with patients who have an uncertain neurological outcome, and really trying to help the patient's families make sense of what we know and what we don't know about what the future is going to hold for the patient. So oftentimes the most common collaborations happen in stroke, subdural hematomas, status epilepticus, and I've seen more encephalitis in the past year than I think I've seen for the rest of my career. 2 weeks ago, I saw a patient in the hospital who had CJD that was finally diagnosed, or at least the lab result finally came back. I would say that there's also a natural collaboration that we have with dementia, not just other progressive neurologic diseases. And some of those we see in the hospital, but many we don't.
I was curious, and Nupur, I apologize if you're getting into this a little bit later on, but I was just curious to know, I didn't see this specifically, but from both of your standpoints, especially Renato, with some of these kind of end-stage Parkinson's patients, is there ever a time that it's a too early time to get palliative medicine involved with some of these people? Do you ever feel like it's too early, or is it often that you're getting involved too late? Can you comment on the timing of when you both end up getting involved in some of these cases and whether or not you think it's appropriate or not?
So in our clinic, I think there's never a point where it's too early or too late. Just like at the cancer center, whenever I see a patient for the first time, they often wonder, what am I doing here? I'm not dying. But I tell these folks, the beauty about what we do is we can insert ourselves anywhere in the spectrum. And a lot of the patients that I see over at the cancer center, they've just been diagnosed. They're just starting their first line of treatment. And then on the other end, I can be seeing somebody who's getting close to the finish line and getting close to head towards end of life care. And same thing at the neurology clinic. I can be seeing somebody. A few months ago, we saw somebody who's still driving. Not that it's the safest thing to do. And what's even funnier is that he drives to the firing range and might do a few rounds. Again, not the safest thing to do for a patient of his type. But then again, we might see, and oftentimes we see this. We might see somebody who's nonverbal, who's not able to perform any activities of daily living on her own or by himself. And so there's really no defined time point where we need to be involved. I think the knowledge that Dr. Margolius, my neurology partner, has spread in the department or in their institution is that whenever somebody has an increasing amount of symptom burden or decreasing quality of life, then we need to get involved. And the other piece to that is if their caregiver is starting to really feel the burden, then we need to get involved.
Yeah, I would say that similar there, you might see a patient and we might meet them, talk to them, and if it's very early in the disease course, we might not have much to offer that's different than what's already happening. But usually it's not time that's wasted. I feel like that question often comes because, and I'm hoping this gets better with time. So thank you for having us on, because the more people realize that palliative care is there to come alongside the patient and family and figure out what they want, rather than an old thought that palliative care is going to get on board and just try to get somebody to die quickly and comfortably. As long as people realize that palliative care really is about what is the patient and family's goals, then it's not too early. And unfortunately, that's why we sometimes in the hospital, I see it too late, because the medical team is trying to figure out, like, can we get this person more time? Can we turn this around? Can we fix this? And we're actually, that's a great time to have us involved, because then we're meeting the family, we're hearing about the patient, and we're starting to hear some of their goals, their values, what they want out of life. And then that often plays into what they choose for what the patient may or may not go through in terms of trying to get more time.
Yeah, thank you both for the comment. And it's something that sometimes I think we as neurologists sometimes struggle with, is when do we get you all involved? And I really wanted to point out to everybody listening to that you both mentioned an important part of this that sometimes we don't think about, and that's the family or the caregivers that can also benefit from obviously discussion with all of you, especially in our neuro patients who may not be as adept to expressing their own wishes. I know that that's a huge burden on the family and caregivers, and I've seen just how much power and strength you give a lot of the caregivers when making some of these decisions. So I hope that people were listening along to the fact that you both independently had mentioned that part of it. I think it's really important.
Well, I think there's something to that as well, is that a lot of families, let's say that, the patient can't talk to us, and a lot of families don't want to express their fears to the doctor that's trying to save their loved one's life. And we get to be this neutral third party. I'm not trying to save their life. And so if you express your concern to me, or your worry, or your hesitation, you're not then also thinking as a family member, oh, if I said this out loud, they're not going to go forward with what they're planning. So I do think that there's that separation that's also often helpful for families, for sure.
Katie, I've never thought of that before. So
Yeah. And I'd like to add that I think credit goes to before we started the clinic, one of the first things that we did was to travel to Edmonton, Canada. So we spent the day with Dr. Janice Miyazaki, who's one of the big names in neuropalliative care. She let us shadow her team at the University of Alberta. And that's where we found this really great model that they do, wherein her as the neurologist, and then there's a palliative care specialist and a social worker / chaplain who's really a powerhouse. I mean, that's a great combo. So all three of them see patients at the same time, patients and their family members. So instead of everybody telling their story, 3 times, which gets really exhausting. I mean, everybody's there, an hour spent with everybody in the same room. And so we adapted that model, and right there and there within that hour, we are able to talk to all the parties involved, the patients if they're able, and more so the family members. And then everybody gets to hear what the concerns are and what resources we might be able to offer.
Well, and Renato, this happens in cancer, and similarly for the patients. A lot of times the patients don't want to let their doctor down. And I would imagine you might see that in the neurologic diseases too. Like, you've been treating my MS for so many years. I don't want you to think that I'm ungrateful by saying I don't want to do this anymore. So we definitely see this in cancer. And I think as we get more and more into the neuropalliative space, we'd see if that's also true in the neurologic diseases. And again, another reason that we can, come alongside and assure patients that their doctors want the best for them, and whatever that looks like, and that they're not letting somebody down by saying, maybe we shouldn't do this anymore.
Mm-hmm.
I'm just like, my mind is firing faster than I can keep up with right now, because I think of all the points that you're making, and it sparks more and more thoughts from me. And I just wanted to follow up with one more. And that is something that you both described about this kind of dichotomy between, is it nice to have your neurologist there during these conversations, or your medical provider? Or do you think that sometimes, in Katie and some of the patients that we've shared in ICU settings, sometimes it's really nice to have a whole team of people there so that we're all on the same page, especially when this is very multidisciplinary. But what you just said also makes me wonder, is there an appropriate time to where we shouldn't all be doing this? Is it overwhelming for the family to have so many different people there? And so how do you approach when to involve other team members? And do you think that having some time outside of, I guess, Renato, for what you said, where they all do it together, do you think that there's some value in just allowing the family to be able to meet with, say, just you, and leave their medical provider out of it for some of those more confidential conversations?
I think we've only done that once, and only because Dr. Margolius had to clone himself and do something else, or see another patient. But now, I mean, for all other visits, and I mean, we've been doing this since 2020. We've always acted as a unit, worked as a team. And I'm thinking, just to your point, Blake, especially if say somebody it's a if I'm in the other building and seeing somebody with dealing with cancer. I mean, ideally, I would love for his or her oncologist to always be there so that we can all be on the same page. Because sometimes what might happen is somebody might be seeing his or her oncologist or neurologist whom they probably been following with for a long time and establish a really lengthy and meaningful relationship. And here comes me and here comes Katie meeting them for the first time, imposing our will, telling them what they should do, what they should not do. I mean, that can sometimes be uncomfortable. So I think, especially in the neurology setting, it would be, for lack of a better word, ideal to have somebody there, a familiar, face, a familiar presence with the patients and their families, having this discussion with this stranger about serious things, about end of life stuff and about care towards the end.
And I think to that point, when we're there, we can often gently ask the patient, even if they're long-time providers, there questions like, are you worried about stopping? We can ask the questions even with their provider there in a way that hopefully they feel comfortable to answer. I would say in the inpatient setting, I often meet patients and families first without the team, because that gives me a sense of what they know, what they don't know. And then that way, if there's a lot of unanswered questions, then we can come together as a full group, or if, the family's on separate pages. There are some patients and families that they feel pretty confident and they know what they want to do. And I think that saves everybody time if they can tell me, and then I just can come back to the team and we don't have to have that bigger sit down meeting with everyone. But I don't know. I mean, there aren't any studies that I know of one way or the other to know what the best would be. So it is an interesting area to think about, what helps. Oftentimes there can be a huge part of our role that is just listening and empathizing, and for better or worse, being a doctor who's doing that means something to a lot of patients who feel like they haven't been heard in different ways in terms of what they are looking for and what they're hoping for. And so I do think that helps.
Yeah. Plus it also helps that I mean, my background is internal medicine. I don't suffer from neurophobia, but it certainly helps that that Dr. Margolius is there with me in case, and this often happens in case a family member or the patient asks something that's Parkinson's disease related or neurology related. They can get their answer right away.
And then if we weren't there, it can be helpful in a different way. A patient might ask something like, well, how long until, I'm not able to do this activity? And I wouldn't know the answer. I would say, what are you hoping that they're going to tell you? Well, what if they said this? What if they said that? And even finding out the unknowns, while I also don't know the answer, and trying to figure out what their what if answers would be, can be really helpful. And so then when they do get the answer, then you can come back and say, is that still true? I know you were hoping for longer, and your doc, she said it was going to be sooner. What does that mean? Yeah, we love our jobs. I love my job because medicine in and of itself can be rote in many ways, but why people make the decisions that they make in the same circumstances as another patient and their outcomes are completely different, it's fascinating to me. It's fascinating to me why people choose what they choose and what quality means and how they want to live their life.
Absolutely. Well, there have been so many wonderful points made, and something that really stuck out to me, Dr. Samala, you said it very early on when you were describing palliative medicine being the spectrum, and the moment that you enter is very different for different patients, and the journey, no matter how long the length is, is meaningful because you play such an important role in, as you said, Dr. Neuendorf, of being there, of empathizing, of being that listener that sometimes patients don't get. And with patients that have neurological disease, I mean, what better thing than to have them be able to share that burden with some third party person. And you know, it's just, as you said, it does take a village. And so the collaboration it's so evident from this conversation alone. And I just wanted to switch gears a little bit because we've been talking a lot about the threshold in which palliative medicine sort of gets involved with neurology. And so I wanted to look at it from the other aspect, because a lot of the literature regarding neuropalliative medicine focuses around this idea of neurology being primarily palliative. Since a lot of the conditions are these long chronic diseases, there's a belief that neurologists should sort of function as palliative medicine doctors and hold that primary role. And so I want to know, Dr. Boleko, as a vascular neurologist who works in the ICU, who also works in the outpatient setting, you know, what is your level of comfort when it comes to having these conversations with palliative medicine? And what is the threshold for you in regards to getting palliative care involved?
Yeah, this is a good question. And it's something that I think, you know, a lot of my colleagues and I may do differently. I think that we all have our own thresholds and we all have our own comfort. I think we as neurologists, maybe there's there's a lot of different types of neurologists, but maybe there's the neurologists who go into neurology trying to solve all the unknowns and trying to have definitive answers and answer a lot of these diagnostic dilemmas and come up with treatment plans where maybe before in the past there weren't treatment plans. And then I think a large majority of us go into neurology knowing that there are a lot of unknowns, that we have to be comfortable with that. And we've talked about that on a couple, you know, episodes previously about being comfortable with saying, I don't know in neurology. It's not something that is a sign of weakness. It's a sign of our limitations and what we know. It's a sign of strength whenever you're able to communicate that with patients. And so I guess what I'm getting at is it's a very individualized, I think, provider specific feeling of what they're comfortable with. How comfortable with end of life care are you? You know, I think whenever I see patients in the hospital or I see patients in the outpatient, and you can clearly see that symptom burden has gotten too much, or you feel like they are suffering, their quality of life is suffering. I'll be honest with you, I typically, I know my limitations, and I know that we have a lot of great people, like the people on this podcast, that really, really do a wonderful job at helping to bridge this gap for us whenever we feel like we don't have all the tools in our toolbox to be able to handle this. And that's typically my threshold of, I feel like there's something more that I can do for them. Maybe it's not a diagnosis, maybe it's not a medical treatment that I can give them per se to reverse whatever disease I'm helping to treat, but I know that there's more. There's always more that we can do. And I find that that's my threshold of, I know that there's more, but I don't know what that is. And I know that people like Renato and Katie do know. And so I think getting them involved, I'll be honest with you, I don't hesitate to do it earlier on the inpatient side because there is a lot that happens very, very quickly. It's usually very unexpected for some of my stroke patients. And so it can be very overwhelming very quickly. And we have to make decisions fairly fast. And so my threshold is lower on the inpatient side. And I'll be honest to Renato and Katie both, I probably don't use palliative medicine services on the outpatient side nearly as much as what I should, maybe because that's a subspecialized role that I feel sometimes I play. But we do a lot of primary care, you know, things for our patients. So why are we also not thinking about longitudinal palliative medicine for some of our patients with chronic disease? It's probably not something that I do enough of. So I think it's very different, Nooper. If you ask 100 neurologists, they would probably all have a different comfort level. You know, if you ask them what their comfort is from managing kind of some of these chronic conditions and approaching from a palliative approach, you'd probably get a different number from everybody. So I see a lot of variation.
Fair enough, Dr. Boleko.
Yeah, and if I can go off that, I also feel like many places have cultures in terms of what this looks like. Right now, at least at Cleveland Clinic, we don't have a neurologist who's also a palliative care doc. There are some programs out there that do, and that collaboration is going to be a lot more it just will seem like a more natural collaboration because you have that person that you can lean on. So maybe that's where we need to come, all you budding neurology palliative care docs out there, come help our program grow in that way. And I would say, Newbert, I think that neurologists are great palliative care docs. And I would say there are many times that you don't need that specialized look at a patient because you are handling it. You have the relationship, you know what they do and don't want in the future. So I think there are many times that, or in the hospital, you've had that conversation. The family seems very clear about the patient, what the patient does or doesn't want. Great, you probably don't need a consult for us then. So I would say that while we would both say there's never too early time to get palliative care involved, you don't always need us. And I would say that that's okay too.
Yeah, and I also wanted to add that in the clinic setting, in the outpatient setting, at least from what I see, I mean, it does take a village, but all the village people are there. There's the neurologist, there's a good number of social workers and good ones in the neurology team. There you have a psychiatrist, a psychologist, an army of therapists. So everybody's already there. You just need to assemble your team. Call on us when you think you need more assistance in advanced care planning and managing maybe difficult to manage symptoms. But all the tools, all the personnel are already there.
Yeah, I think one of the main times that specialist palliative care can be helpful, at least in the hospital, is that when you are giving factual information to a patient or their family, and they keep pushing back against factual information. You're bringing them the truth, you're letting them know what's happening, and they keep arguing with you about truth. That's actually we see that situation in many different ways. And I would imagine, Blake, that sometimes I know there's something else here, but I don't know what it is. And we can sometimes get into that a little bit more to try to figure out what the block is, because the block is usually an emotional block. It's not usually a cognitive one.
Yeah, I think these are great points. And obviously this all makes me think about my own practice and our interactions a lot. And obviously I have the utmost respect for all of our interactions that we've had. And I was curious, I know when Nooper was getting this ready, she had made a comment about what might be different between palliative medicine and neurology versus palliative medicine and some of the other specialties of medicine or surgery that you all interact with. And so I wanted to transition into that and really ask you, what makes neurology different from the other kind of diseases or people even that you interact with day in and day out?
I can, from an inpatient side of things, one of the main differences is the acuity. So if you think of stroke or status epilepticus or something like that, you have a person who is well, and then a person whose life has completely changed, at least the patients that I see. And it is hard for families to make decisions in that state of shock. And in other cases, and even in some other neurologic illnesses, there is a predictable progression of what this is going to look like over time. So I think there's that piece, the acuity. And I think the other piece that's fascinating to me is that if, let's say I have a patient with heart failure, and if I talk to them today and I talk to them 6 months from now, they're either going to be the same or worse. And if I have a patient who just had a stroke and I talk to them 6 months from now, I don't know what that's going to look like 6 months from now. And you don't always know. Nobody knows. That back to the point of, being able to say, I don't know. We don't know what it's going to look like 6 months from now. And I actually think that's really hard. When it's a predictable course, people can get a sense of like, this is what I want. This is what I don't want. This is my stopping point. But when it's unknown, and if it's unknown on top of shock in terms of that this happened at all, I think it can be very hard for patients and families to figure out what to do next. And I have a lot of empathy for them in those moments. So that's what I would say in terms of a lot of the difference I see with patients with neurologic illness.
Yeah, I can make three distinct points that kind of differentiate the hat that I wear when I'm in the cancer building, and then the other hat when I'm with Dr. Margolius and his team. Point one is symptomatology. I in my 3 years of working with the neurology team, I've never ever prescribed an opioid medication. Is that a win? Maybe, but I think it just speaks to the difference in terms of pain between the two patient populations. I mean, at the cancer building, it's opioids left and right, because these patients suffer from severe cancer-related pain. But in neurology, it's mostly pain from muscle spasms, spasticity or rigidity. So a little bit of Tylenol oftentimes does the job. The more prevalent symptoms that I manage in neurology are constipation, insomnia, depression, and anxiety. Not to say that they're not common over at the cancer building, but they are far more common over in neurology. And then the second aspect is trajectory. As Katie was saying, patients with cancer, when it's metastatic, and if they decide to stop treatment, it's automatic, 6 months or less. But patients with advanced Parkinson's disease, they can go on and on. They can keep going. With the proper care and with all those new drugs coming out, which I'm learning every time I'm there. There seems to be new stuff every time I'm over there. There's this just to go off a tangent. There's this drug called Dua Lipa. I'm sure Blake's familiar with that. It's a form of carbidopa, levodopa that's directly implanted to the intestine for better absorption. When I first heard that, I thought they were referring to this British pop star, but I guess I guess that's different. So there's just it's just a new world, a new universe whenever I'm wearing that hat. So trajectory is different for sure, which brings me to the third point, caregiver burden. That seems to be at a whole different level compared to the family members that I see over at the cancer center, because they are in charge. They're responsible for taking care of their loved ones, not just for weeks, months, but years and years. So it really takes a huge toll on them, and they often get to that point where they really need help in many ways. Okay.
Yeah, you guys have probably heard this before. A patient gets diagnosed with cancer, and like the whole community knows that's bad, and this is probably what your life's going to look like, and this is how we can help and adapt. But there are many diseases out there that might be more burdensome in different ways, but they don't have the same level of community recognition or support.
Absolutely.
Yeah, Nooper, you can at Dua Lipa on the Twitter feed for this.
It's definitely going to be going in the episode notes. What wonderful points that you both just made. And it makes me really excited to be going into neurology, because there is that unknown when it comes to these patients, and that can be terrifying, but it also can be so exciting, depending on how you look at it. And I think that's probably why I'm going into the field I'm going into. But something that I really wanted to talk to all three of you about is something when we think about neurology and palliative medicine, sometimes these fields often get labeled as depressing or without hope. Neurology, there's a lot of conditions that are not curable. They're lifelong conditions. And in palliative medicine, as Dr. Neuendorf, as you mentioned, there's the stigma of, once I get involved with palliative medicine, that's the end of the road for me. I'm really curious from your experiences, from your perspectives, how do you maintain hope and healing in the face of difficult neurological diagnoses and variable prognoses for these patients?
Yeah, the first comment that comes to mind for me is that I think it's because people mistake sad and depressing, or at least equate them as being the same thing. There are a lot of situations I deal with that are sad, but I wouldn't say that they're depressing. And a lot of that is because human beings by nature have a way of finding hope in really horrible circumstances. And what I feel like I get to bring to patients and families is clarity around what bad looks like, or clarity around what the crisis is. Because in the moments that they know that there's a crisis, but they don't know the definition, like they don't have a good handle of what's actually happening here, what's life going to look like now, what's life going to look like in the future. They know that they're scared, but they don't know what they're scared of. And when I can bring information and clarity with the help, of course, of my many colleagues, but bring it to the patients or families in a way that they understand, I actually get to see beautiful, joyful moments come out of that and see the resilience of human beings in the face of crisis. And so that's what brings me hope. I think the feeling like I can bring those moments to people that were having so much anxiety, and now they know what path they're going to take forward, even when that path might be a pathway to death for their loved one or for themselves. It's amazing. It's actually an honor to see the bravery that people bring to those moments. So I think that's my first thought. I have many thoughts, but that's one, because I think it's a great question. And it's also because people are like, oh, you're a special person to do it. You'd be like, I am amazingly special. But like, how do you ever answer that question?
Yeah, so whenever I think about that question, and I have been thinking about it for the past few days, I always remember I always remember this experience with my wife. Like every time she gets asked by a stranger, by a family member, by a friend, or by somebody, by anybody, what her husband does, and so she goes, he's a doctor. And then naturally the next question is, what's his specialty? And then she goes, palliative care. The most common, the most usual reaction that she gets is, oh, that must be hard. That must be sad. I don't know, you probably get the same thing, Katie, or whenever your husband gets asked about what you do. But it's a very common reaction. But palliative care can be fun, especially in the outpatient setting. It really can. And I think, again, 2 points. The first point is it alludes to what Katie was saying, that in the face of adversity and uncertainty and crisis and what the next steps are, I often tell patients that we don't know what's going to happen. We will just need to cross that bridge when we get there. But now that we're involved, now that our team's involved, we will get to that bridge at the same time, and we will cross that bridge together. You and your family members. Now that we're here, now that we're involved, let us have your back, and we will face these crises together. And that brings them hope, that brings them joy, and that brings me joy myself. And then the other thing is just celebrating wins. Small wins in clinic, maybe small wins in the neuro ICU. When something happens, I make it a point to celebrate those wins with my patients. Somebody coming in with frequent falls, and then we intervene. Maybe we recommend physical therapy. We adjust their medications for orthostatic hypotension, and they have 2 less falls in a week. And we make sure that we celebrate that. And so, those are the things that bring us joy.
I think Nooper, for me too, I mean, as a stroke neurologist, I can sit here and talk about TNK or thrombectomy, and I can see people change before my eyes. But if we stick on the same kind of path that we're on right now, strokes, when I see them have this stepwise decline over time, I think that I think what gets me through this is developing even stronger relationships with the patient and their families during those times. And that one of my biggest pet peeves in medicine in general is when I hear the words, "There's nothing more that we can do for you." And so I feel that there is always more that we can do for our patients. It may not be giving them a new prescription. It may not be anything more than bringing them in every couple months, allowing them to have a full hour to just chat about life and what's going on and what quality of care looks like. And that changes. That's a moving target. And I think patients come to those realizations on their own. I think families do that also, but I think they need a little bit of guidance to get there. And so I think if I have a conversation with a patient where we can just sit and we can talk about what quality of life means, and I can give them at least my best understanding of what a prognosis moving forward looks like, I almost feel like my patients get more out of that than me managing their antihypertensives or their hyperlipidemia or diabetes. I honestly do think that some of those conversations are more meaningful for the patient and for the caregiver than some of the conversations that we've had surrounding their medical care, within the years prior to that. So I take joy in some of those. I think that that's part of the humanistic nature of medicine. And if you ignore that part, then you lose some of your empathy. And I hope that never happens to me. So I try to always remind myself that there is something that we can always do for our patients, no matter what.
Beautifully said.
Yeah, like I think of, I came to palliative care through internal medicine as well. And I've never had patients thank me for the life-saving measures of getting their A1C controlled as I have for giving sometimes horrible information about what the future is going to hold. But the gratitude in terms of at least knowing, again, and I think that gets back to human nature of when you know, you're going to deal with it, and when you don't know, it's scary.
Absolutely. This made me think of a follow-up question, because I know that a lot of people who are considering going into medicine are afraid of becoming jaded or cynical by all the bad that you can endure or experience when you're going through medical training. And so I'm wondering, as specialists in fields that are sometimes considered sad or hopeless, how do you guys fill your buckets? How do you maintain your own battery level when you have to sometimes deliver terrible news and maybe there aren't those tiny wins to celebrate in a day? How do you recharge and restore yourself in your practice?
Renato, do you want to go first?
Yeah, sure. Yeah, I think for me, family is a big part, and setting boundaries. So yeah, I do all that amazing stuff at work, but then when I get home, I make sure that to flip a switch off. I'm home, I'm done. I finish all my documentation at work, and then when I get home, it's all family and fun time. I think that's a big thing. And then the other thing is like what you said, you're celebrating those wins, not dwelling on the bad things that happened that day, but instead rejoicing at the triumphs that I was able to achieve. And then prayer and faith, that's also a big thing. Yeah. Katie?
Yeah, Renato, I would say a few things. One of the thoughts that comes to mind is potentially another reason to consult us. And sometimes it's just to share the hard, yeah, I had this horrible case on Friday, and I brought it to my partners to say, here's the situation. What do you think? This is what I'm thinking. And one of my partners said to me, said, absolutely, I agree with you. And who's going to go with you when you talk to that family? Because it was just that tragic. And that's how we can help too. It's like to share the hard, and so I shared it with my team, and then they knew I was going through that. And then they checked on me later today. So I mean, kudos to my team all the time. Renato, I agree with a lot of the pieces that you said. I think what I would add to it for myself, exercise for me. So, I store all of the emotion that I have, but I don't express in the moment with patients and families, lives in my traps. And so some sort of movement, I get massages to get those pieces out, but sometimes I'll also go into a spinning studio where the lights are low, and I spin and I cry, and then I feel better. So I think, trying to figure out, at least for me, is where do I store the grief and the sadness? And then how does my body let that out? And so for me, it's movement. Like I have to move to get it out. It's not thinking for me. I know other people will meditate and pieces like that. For me, I grieve in action.
Nooper, I'll take it in a little bit of a different direction because I know that you don't want me to talk more about myself, and we've heard enough of that. But what I will say is we had a resident who really did a lot of our wellness initiatives several years ago. Her name is Liz Spurgeon. She's an epilepsy specialist now at the clinic. And she came up with an idea of, we do this as a team. We share the heart as a team, but it's very rare that we debrief about some of these things in a team setting. I think that it's something that we probably could do better at. I know there have been conversations before that we've had and outside of this podcast where there are not many other fields of work where you can code a patient, you can watch a patient die in front of you, and then you can turn around and you can go back to work. And so I think that this is very difficult. And so what Liz said is, why don't we initiate something called joy rounds? And I said, Liz, what are joy rounds? And it's basically where part of your daily rounding is talking to each other about the good things that are happening, the small victories, as Renato has said. And this can be patient or non-patient related. And so what this has turned into, it's turned into some coffee, it's turned into some snacks, it's turned into, what are you really proud about this week? What happened outside of the hospital after you went home? Were you able to go and walk around the Metroparks? Were you able to take advantage of the sunshine? Did you have a big life event that you want people to know about that's kind of uplifting you? Or were you really happy about something that happened with your patient, or something that you had a direct say in that helped your patient out quite a bit? Are you happy that a patient is improving, or that you had a hard conversation? And I'll tell you, I don't do it as often as what I wish that I still did, but whenever we do this and we implement this into your rounding style, it just creates a different dynamic within the team. It does recharge you as a team, and it reminds you that while you're doing the bad news business that a lot of us do, there's a lot of good. And I think, to Renato's point, you actually sit there and talking about the victories out loud is so powerful. So for anybody who's looking to change up your, educator experience or your rounding experience with your team, try joy rounds and just take a moment to reflect on the good things that are happening too as a team. I think that's really, really powerful.
I love that you guys do that. That's awesome. Our version of it on the inpatient setting is Cheesecake Fridays. That brings us all joy.
And on the side, we do it more often pre-pandemic, but we find to celebrate, and we have potluck where we have clinic. Yeah,
Food and coffee. It's
exactly.
places of joy.
Yes, completely agree. Well, I know that we are winding down, but part of this podcast is really to shed light on some of the love for neurology, but also stems from people's fear of neurology and this neurophobia. So I was just curious if either of the two of you have experienced neurophobia, when you see some of these neuro patients, either in the inpatient or outpatient side of the world, what scares you about neurology? What scares you about these patients? And can we as neurologists do anything to help palliative medicine specialists ease that neurophobia?
Renato, you said earlier you don't have any, but did anything come to mind for you?
I'm
Renato,
not gonna.
that's rare. That's rare on this podcast, which I absolutely love. So I'm interested to hear your perspective on.
I've also been thinking about this question for a few days now. I'm not gonna say that I'm the best student in neurology, in neurosciences when I was in med school. The way I've viewed neurology, neuroscience, all that stuff is I see it as math, as mathematics. I'm not terrified by it. I'm decent at it. I don't love it. I think I know enough to work my way in your world. But I think what scares a lot of people is it's a whole new universe. There's so many things to know, to remember, to understand, and you can't just memorize things. You gotta understand how this works and how that pathway works, how this drug affects the brain, etc., etc. So I think for me, if I was somebody suffering from neurophobia, I think it's just the huge breadth of information that one has to not only know but understand. That's the scary part.
For me, I'd say that what comes to mind is I often get scared that patients that we think don't understand us or can't hear us really do. And they may never be able to find a way to show us that. So that's one of my fears in general. And I would also say, there's a lot that we don't know about the nervous system, and we only use this small percentage of our brains. And so what else is going on up there? It's scary to try to think about that. And, why aren't we using more, and what's happening, in the downtime of all of that, the diastole of our brains, scary to me.
I like that phrasing a lot. That's honestly how I feel about the ocean too. There's so much of it we don't know, and that terrifies me.
Yes, but it's all turning to plastic.
Good comparison.
Yes. I want to thank both of you sincerely from the bottom of my heart, Dr. Neuendorf and Dr. Samala, for joining us today on the Neurophilia Podcast. Before we conclude, I wanted to ask you both about your no-brainers, and these are going to be 5 questions that you can respond to with 1 word or 1 sentence maximum. Are you ready to go?
Ready.
Ready.
I'm as ready as I can be.
You're as ready as you can be. I love to hear it. What was your favorite part of this conversation?
Sharing it with 3 great people, including a colleague I respect. No, I was talking about Blake, Renato.
I knew that
was like, wait a minute. She just said one of us, Renato. So do you want to rock, paper, scissors for which one?
It was Nooper. You are well done. Yeah.
That's fair. We can all share that.
Well, my favorite part of this conversation is just sharing what Katie and I do with the rest of the world, because I know this podcast will go on YouTube and what other channels are there. It's got an international reach. You guys are world renowned, I assume. So just letting the world know that palliative care exists. We do good work, and we work well with all specialties, including neurology.
Absolutely. What do you hope changes in medicine within the next 10 years?
Doctors have a more comfortable relationship with death.
Every provider, I guess excluding radiologists and pathologists, being able to comfortably perform primary palliative care.
I love that. What is your favorite part about being a palliative care doctor?
I enter into spaces that a lot of other people are afraid to go. And I bring knowledge with me that helps.
I guess I have two favorite parts. One is the collaboration that I form, that I make. And second is it's not as sexy or prestigious as neurosurgery or heart surgery, but it's very darn satisfying personally and professionally.
Absolutely. What do you enjoy doing outside of medicine?
Nature.
Traveling with family.
And what are you most proud of?
Jeez. Oh gosh. The relationships I've built along the way.
The growth of our department, especially in recent years. We've grown from just being a small group here at main campus, and a small group doing home-based hospice and palliative care, and that's expanded exponentially just over the past few years.
Thank you both so much. I have a quick conclusion to do, if that's all right, and then we'll be wrapped up. I know we're a little bit past 6. In this episode, we discussed the relationship between neurology and palliative medicine, the resiliency of neuropalliative patients, and the importance of empathy, compassion, and celebrating small wins in patient care. Thank you so much to our guests and to you, our audience, for listening to this episode. If you enjoyed it, please leave us a review and follow us at Neurophilia Pod for updates on future episodes. See you next time.